Okay, good morning. Now let's see some of the common causes of optic disc edema. Now, when you see an optic disc swelling, it may be due to an intrinsic ocular condition, it may be an intracranial lesion, or it may be a systemic disease. Now, when you examine a disc, find out whether it is a true disc swelling. Is the optic nerve function affected? Is it unilateral or bilateral? Is the disc hyperemic or pale? Now look at this. You can see the disc is elevated. It's hyperemic. The cup is full. The vessels are dilated and tortuous. The margins are all blurred. There is obscuration of vessels at the disc margin. You also see hemorrhages, exudates, and edema in the peripapillary region. And this is a true edema. Whereas here you can see the disc is elevated, the margins are irregular, but there is no obscuration of vessels as they leave the disc. You don't see any peripapillary hemorrhages, exudates, or edema, and this is a pseudoedema. Now let's see some causes of disc edema. Now if it is bilateral with normal vision, it may be an early papilledema, a grade 4 hypertensive retinopathy, or a diabetic papillopathy. And if it's associated with the decreased vision of sudden onset, it may be toxic, like in methanol poisoning. It may be an atypical papillitis, sequential involvement in AION, or inflammatory conditions. And gradual, it's a vintage papilledema, and sometimes compressive or infiltrative lesions affecting the optic nerve. Now, patient complaining of headache, tinnitus, transient obscuration of vision, visual acuity recorded is 6 by 6 both eyes, but the fundus shows a hyperemic disc edema with dilated vessels and few hemorrhages, exudates in the peripapillary region and in the macula. We think of an established papilledema. These patients require an urgent systemic and neurological workup. You need to do MRI brain and MRV and sometimes a lumbar puncture. You have to rule out causes like a space-occupying lesion, intracranial bleeds, meningitis, idiopathic intracranial hypertension, and venous sinus thrombosis. Now, a grade 4 hypertensive retinopathy, usually seen in young patients with uncontrolled BP. Again, it's a bilateral hyperemic disc edema. The arterioles will be very narrow. You can see streak hemorrhages and soft exudates extending well beyond the disc, and you can see hard exudates also in the macular area. So make it a point to check the BP in the OPD itself before sending the patient for a neuroimaging when you see a bilateral disc edema. Diabetic papillopathy usually presents as a mild visual loss. It may be unilateral or bilateral. You can see the disc is mildly hyperemic, and mild disc edema is seen along with features of a moderate NPDR. Sometimes you can see telangiectatic vessels also on the surface of the disc. It's considered to be a mild form of NAION and usually spontaneously improves over the coming months. Weak age syndrome also presents as a bilateral panuveitis. Here you can see that along with disc edema, you can see some multiple serous detachments of the sensory retina, and sometimes even exudative detachment may be seen. Now look for other signs like a neurosensory deafness and signs of meningism. Make it a point to look beyond the disc. Don't just concentrate on the disc. Now coming to unilateral disc edema, again causes with normal vision, it may be an asymmetric papilledema or an early non-ischemic CRVO or a diabetic papillopathy. If associated with a decreased vision that is gradual, compressive or infiltrative lesions of the optic nerve, or it may be a Faust-Kennedy syndrome. Sudden can be painful and painless. If painful, think of optic neuritis, a neuroretinitis, posterior scleritis, uveitis. If painless, it may be an anterior ischemic optic neuropathy, Leber's hereditary optic atrophy, ischemic CRVO or ocular hypertony, and also examine the other eye carefully to rule out any subtle disc edema or disc pallor. Now, a typical optic neuritis presents as a subacute monocular visual loss. A typical case usually is seen between 20 and 45 years. Characteristically, the patient complains of pain on ocular movements. The findings are similar to papilledema, but the disc edema is less marked as what you see in papilledema. Main causes are demyelination, others are infection and inflammation. You have to do the relevant investigation to find out the cause of optic neuritis. Now, a patient slightly older, more than 50 years, complaining of unilateral, sudden, painless, and profound loss of vision. You see that the disc, you can see a diffuse disc edema that is slightly pale and hemorrhages on the disc surface and also extending into the peripapillary region. This starts as a hyperemic disc edema, but as days evolve, it turns into pallor. You can also see there is an absence of cup, and in the other eye also that it's called a disc at risk. A clinical diagnosis is a non-arthritic AION. The systemic risk factors associated with this are hypertension, diabetes, dyslipidemia, a nocturnal drop in blood pressure, or an obstructive sleep apnea. In the young, hyperhomocystinemia is an important cause. You have to control all that to prevent involvement of the second eye. Neuroretinitis seen in young patients, complaints of pain on ocular movements. About 10 days or 2 weeks after the onset of disc edema, hard exudates also start appearing at the macular area. Common causes are toxoplasma toxocara or a cat scratch disease. Now, when you see these hard exudates, we can exclude demyelinating conditions. Arthritic AION, it's in the more elderly age group, unilateral, profound loss of vision. They may complain of headache, jaw claudication, of scalp tenderness. Temporal artery is tender and pulsations are absent. You can see a pallid disc edema, and ESR and C-reactive proteins may be elevated, but a temporal artery biopsy is the diagnostic tool. So you have to treat the patient promptly because it's mostly due to a giant cell arthritis. Otherwise, the second eye also can get involved in the next few weeks. Leber's hereditary optic atrophy, usually seen in males of the younger age group between 15 and 35, complains of unilateral, severe, painless central visual loss that occurs in a stepladder pattern. You can see the disc is hyperemic and mildly edematous, edema spreading to the surrounding retina. Sometimes you can see telangiectatic vessels also in the peripapillary region. Mimics an optic neuritis, but here the family history is very important. It's maternally inherited. The second eye is also involved the next few weeks. The prognosis is not good. Ischemic CR view, we are not going to misdiagnose this. You can see disc edema, veins are very much tortuous and engorged. You can see hemorrhages and soft exudates extending up to the periphery. Now, compressions with the optic nerve may be due to optic nerve glioma or a meningioma of the optic nerve sheath. The disc is swollen, and sometimes you can see opticociliary shunt vessels also. Rarely you can see such a picture due to infiltrations to the optic nerve due to lymphoma, leukemias, or tuberous sclerosis. Posterior scleritis, a patient presents with a dull, boring periocular pain and sometimes a mild visual loss. They have disc edema, macular edema, and choroidal folds, sometimes an exudative retinal detachment. Then hypotonic maculopathy, following surgery, especially the trabeculectomy, or it may be post-trauma. IOP can fall down to 4 to 5 millimeter, and the axoplasmic transport there is a stasis of axoplasmic transport resulting in disc edema and folds. Now, in all cases of disc edema, we need to do a detailed history and a thorough clinical examination. Often, we may have difficulty in distinguishing atypical optic neuritis from a non-arthritic AION. Here, relevant investigations help us to reach the diagnosis, and visual field testing in our OPD is a very important tool. Start the treatment early if possible, and in most cases, we can prevent the optic disc from going into a pallor. Thank you.